I'm pushing the arrow and nothing's happening here. Okay, here we go. Okay. Disclosures. Everybody has to have their disclosure slide, so this is mine. I receive financial support from my employer, and I'd like to continue to do so for the next few years until I'm old enough to retire. And they may not agree with the content of this presentation. I have no real qualifications to talk about the future. I've never been there. My only qualification is I've been a clinical geneticist for the last 25 years, so, and I am in the trenches. I'm going to reference any hard data I could find about where things are going, and you can assume the rest is my opinion, and you can argue with me accordingly at the end of the presentation. I think all morning and you know, all the time, we're all in genetics, and we know that the ability to perform genetic testing has increased exponentially over the last 25 years. When I started out in clinical genetics, you know, we had a karyotype, and high-resolution banding was a big deal. And we were still doing, I'm embarrassed to say, we were still doing Fragile X by looking at it under the microscope. And, you know, patients would come in and we either recognized what they had, and we did the karyotype and the Fragile X, and, you know, you hope for the best. And since then, I mean, there's just been an explosion in the amount of testing that's available to us, and things that we used to have to diagnose by just looking at and recognizing now all have diagnostic tests. That said, I think, and you may or may not agree with this, certainly our genetics clinic, most of us have kept the similar structure that we had 25 years ago now. You know, I think about the only thing that's changed, at least in my clinic, and maybe it's not changed in yours, I don't know, but, you know, the counselors don't write these long, long letters to the families anymore. We kind of gave that up in lieu of, you know, pointing them to the web. And, you know, when you think about it, when some of us started, the web was in its infancy, and there weren't all these patient resources. And so, you know, that's changed things, but again, we've all kind of kept a similar structure. The other thing that I think nobody would argue with is that this is a very labor-intensive model, and it's not well reimbursed by insurers. We hear that at least once a week in all of our institutions if we work, you know, in academics or anywhere. It's just not well reimbursed, and the other part of it is it's not well understood by anybody outside genetics. They can't understand why it takes us so long to see a new patient. They can't understand why we need social workers and dietitians, and why people can't bill for those services. They're used to a model where you come in, you do the tubes, and you send them on their way, you know, and you get a lot of money for that. So that's kind of where we are. So why do we do it if, you know, if that's the case? And I think the reason is the patients need us, particularly those with genetic conditions and the ones that potentially have genetic conditions. The public, now more than ever, because genetic testing's being marketed directly to consumers. You know, I mean, there's the whole 23andMe thing, but, you know, public perception is that, you know, they should be able to go get it, in some cases that they ought to be able to go get a genetic test, and these genetic tests are being marketed directly to the public, and they don't understand them. We are, as geneticists, uniquely qualified to do the job we do. We all spend a lot of time in training, and we all keep up, and we're qualified to do what we do. So the question is, do we have the right care model and the wrong reimbursement model? And I think that's clear. But the other part of that is, you know, when you're in this kind of situation, you have to step back and think too, are there things we could do better? You know, are there more efficient ways we could do things? How can we survive going forward? And this is just to remind me, you get subjected to a lot of, whenever I give a lecture, you're going to be subjected to a horse picture, so just get used to it. There's no problem that can't be solved by riding your horse. And this is from a recent trip I took to Ireland to remind me to start talking about the barriers. The barrier here is there are still parts of the world where you can ride a horse, and the traffic jam is that the farmer is trying to move his sheep from one pasture to the other. And so it holds us up from getting to our destination, and that's the barrier there. And the barriers put our model at risk, really, for what we do for our patients. I think, and we'll talk about some of these, workforce shortages, the lack of financial support for programs, tests that are available, all these wonderful tests that we should have access to aren't being reimbursed by insurers. And if the tests are reimbursed, it's a very time-consuming and frustrating process to get there at times. And our counselors particularly, I think the burden falls on them. They're, you know, doing things that, with their time, that really aren't appropriate for counselors to be doing. They're not seeing patients, they're trying to get tests approved and done. I think there's still a lack of public education about genetics and what genetics means, and most of the people who show up in my clinic don't even know what they're there for. You know, somebody told them to come to genetics clinic, and they're like, okay, I'm here because they told me to come, but I really don't know what you do. There's also a lack of education among other physicians, and I think, you know, I'm hopeful that, you know, the medical schools are doing a better job teaching genetics in their undergraduate curriculum, but I'm very involved with education at Nemours. I'm actually director of education there, and we have 2 hospitals and 2 large practices. And I can tell you that the residents just aren't getting the exposure that they used to get, because even 10 years ago, because duty hours and regulations and this and that, and they're going out to schools to be advocates for, you know, public health and all of that, but they don't rotate through genetics as much. And we keep our patients out of the hospital for the most part, so they're not seeing them in the hospital, and they go out with very little exposure. There's inconsistent licensure for genetic counselors. Some states have it. Our state in Florida doesn't, so that means that the counselors, one, there's no regulation. Anybody can call themselves a counselor and say they're a genetic counselor, and there's no repercussions because there's no licensure. And the flip side of that is, if you do have a board-certified counselor, they can't bill for their services. So it's the double whammy. The labs, the small labs, you know, most of us 25 years ago, I know I had my own lab. And so you see a patient in the hospital, they've got hyperammonemia, you grab a sample, you run over, you do the amino acids, and you got an answer usually within a day at the latest. And now most of the small labs have closed. And it's all finances. And then you've got the big labs that do that and 55 million other tests, and you know, your sample's one of millions, and the service you get is pretty bad, and you try to send them to other good labs, and there's all kinds of barriers to getting those good lab tests. Oops. Okay, go back. What's wrong here? It won't let me go back. Nope. Turn it off and back on. Okay. It's not my problem. Okay, good. I'm glad it's not my problem. Okay. Anybody got something we can do while we're waiting for Windows to reboot? No. Well, it comes under the category of if you wore your Speedo and I sang and danced, we could empty the place. Okay. Okay, back. Okay, now I can go back. Okay, so lest I be too negative, what are the opportunities? One is, with all the genetic testing out there, the public is going to demand access to genetics. It's going to happen. The other thing is our reimbursement system nationally has to change. We just can't keep doing what we're doing. We just can't we can't afford to keep with this system where you do more, you get more, and it's all procedure oriented and all of that. That said, I don't know if it'll change for the better. It's all pretty much up in the air now. The other opportunity is, like everything that we've seen, science will continue to advance. The other thing we have in our favor is that, you know, it's the Hillary Clinton book, It Takes a Village. And it really takes a village to see a genetics patient and to have a good genetics clinic. And our village, so to speak, are the genetic counselors, the PhDs, the nurses, the nutritionists, social workers, the laboratory techs, everybody who puts their hands on a patient sample and who interacts with our patients, and that's so important. And sometimes we forget. We know that, but sometimes we forget to acknowledge that. And that's another thing that the people who, you know, run ENT clinics and run other clinics don't understand why it takes, you know, these other people to help us do what we do. And this looks, I hope you can read some of it at least. This is from the American Board of Medical Genetics. It's taken right off their website about who's getting board certified in genetics. And it's a pretty sobering picture. If you look at 2013, and I'm like Hans, I can't read that, but I can probably read it from up here. The MD clinical genetics in 2013, there were 90. PhD medical genetics, I don't know how good they are at capturing those. Clinical biochemical genetics, 20. So there are not many people being board certified, I think is the bottom line. And you can look at those numbers and the numbers are the numbers, and I don't think 2014 we're going to see a real uptick, or 2015 we're going to see a real uptick in the number of people who are being board certified. And compared to other subspecialties, except for maybe pediatric rheumatology, we're not training many people. And you think, okay, so maybe we're not training so many people in genetics. One model that we could consider is bringing other people into it. You know, maybe we need to engage our pediatric neurologists and our peds heme people, and we need to train them to do some of the things that we do, so that if there are patients, you know, with Gaucher, maybe the hem-onc people can follow them, and maybe the neurology people can share some of this patient load. And if you look at it, this is again off the American Board of Medical Genetics website. These are the cross-training, so to speak, the people who have a board other than medical genetics, what they're boarded in. And you can see pediatrics is the biggest, some OBGYN, and some internal medicine. But if you look at that internal medicine and family medicine, the number in the context of the number of internal medicine people in the United States, it's this many compared to the total population. So that there's really, you know, in our other subspecialties, they're not exactly running out to get trained in genetics. I tried to just pull some data. Maybe Dave Flannery or somebody, you know, who's from the college has, you know, some more information about it's hard to find a number for even just how many clinical geneticists there are practicing in the United States, because it's just hard information to find. So I went to the board and I went to the American College websites, and I actually looked through the American College salary survey, not to get salaries, but just to see what other information I could find. And this was 2013, and the participation rate was 34%, 358 of 1,045 eligible ACMG members. So if you use around 1,000 as maybe the number of geneticists in the United States, I don't know if that's the right number or the wrong number, but it's probably not 10,000. It's somewhere in that neighborhood. To participate in the salary survey, you had to be full-time. So that excluded some people because there are several, and many probably, geneticists who practice part-time. They had 161 surveys completed by either an MD or a DO, and PhDs and MDs without a license, 170. So I just looked through it again. I'm not going to report salaries, but just kind of picking through it to read the verbiage behind the salary numbers to see if we could see any trends. And one was of the MD group, there was a skewing of people who had more than 15 years experience, us old guys. PhDs were more skewed to the less than 15 years experience, which I think is promising. That means there's more younger PhDs than there are younger geneticists, I guess. So, and if you want to look at that as a good thing, I guess it is. It's good for the PhDs, it's good for the labs. The majority of appointments are in pediatrics, pathology, lab medicine, and genetics and medical genetics. One thing that I found interesting and kind of disturbing was that the female geneticists who participated in this survey were more likely to be in non-tenure track positions. And maybe that's because they work part-time. I don't know, but it again speaks back to workforce issues, because, if you're not in a tenure track, what does that say? I don't want to read too much into it, but it may talk to retention, workforce retention, how people are treated. I don't know. And it was most apparent with the PhD group rather than the MD group. And among the male geneticists, the number of non-tenure and tenure were equal, so there was a difference. Retirement. A third of the participants indicated that they planned to reduce the number of hours they spent doing genetics over the next 10 years. And that's sobering. About 24%, so about a quarter, indicated that they planned to retire within the next 10 years, and that was slightly higher among the MDs. It was fully a third, almost a third of the MDs. 12% had changed their plans, half to work longer and half to retire sooner. So half are saying, oh, the heck with this, I'm retiring sooner. The saints are saying there's nobody, which is sad. It was, and I took that as a direct quote out of the report, lack of an available replacement geneticist, no patient coverage available. As a barrier to retirement, and that is, that's a sad situation. So, there are more jobs than there are people to fill them, and there's more of a need than there are jobs. I think that's a fair conclusion. So, if we look out over the horizon, what kind of things can we see to help us address this problem, or can we address it? And what's the genetics clinic going to look like in the future? Is it going to be like this, where there's no geneticist, so there's no patients being seen? There's just nobody there, the doors are closed, and everybody's, well, those services used to be available here, but they're not anymore. Is that what we're going to have? Or, per Olaf's talk this morning, are we going to have a situation where everybody gets all of their genetics prenatally. They do exome sequencing non-invasively on the maternal blood, and they get back tests, and somebody does the counseling, and most of the work gets taken place there, and we're just kind of the dinosaurs that used to roam the hospital and see patients. Or some people have suggested that telemedicine is going to solve some of these problems, to bring genetics to the rural areas and to bring genetics to the places where the geneticists used to be and aren't anymore, or bring genetics to even the acute setting in the terms of metabolism. So I decided to look and see if we could find anything published on telemedicine, and I've asked Hans and certainly Dave Flannery and some of the people in the audience I know have experience with telegenetics. There's been one review that I could find that was in Genetics in Medicine in 2012, and they looked at 14 studies that had been published that had something to do with telegenetics, and some of that was pediatric, some of it was more prenatal counseling. So it was a variety. It wasn't a uniform study. It was a review of just things that had been published. And they reported that throughout the studies there was high patient satisfaction, and that the patients were generally more receptive than the practitioners to a telemedicine consultation. And the conclusion of the paper was that telegenetics, quote, may be a useful tool for providing routine counseling, and that it had the potential to evaluate pediatric patients. So they seem, the thinking in that article was that for routine counseling, telegenetics, may be a good solution. They didn't really want to commit that this was something that would be a satisfactory or useful tool for evaluating pediatric patients. Can you look at the accuracy of telemedicine, if there is such a thing? I mean, we don't know what the accuracy of non-telemedicine is. How accurate is it when a patient comes in to see you? Do you make a diagnosis? Do you make the right diagnosis? We don't know what the real accuracy is. But there is a paper, telemedicine. This study, they had a geneticist on one end and a geneticist on the other end. And the geneticist on the end that was with the patient could not coach or lead the geneticist who was examining the child on the end that only had the TV screen. And they did the exam together. And so the telemedicine doctor, the one who wasn't physically present, identified 93% of the dysmorphology exam items that the person who was present identified. And they also did this with neurologists, not just geneticists. And they identified 92% of the neuro exam abnormalities. So it wasn't perfect. It was 90%, but it wasn't perfect. And you don't know if those are critical misses or not. It's been looked at in dermatology, which is very visual, and a dermatologist could make an accurate diagnosis in 75% of cases. When somebody showed them a rash, they could make a diagnosis. But that's a very different thing, than just showing somebody a rash and saying, what is this, with a bit of history is a very different thing than seeing somebody who has a very complex history. And the ones that they couldn't diagnose were referred to a real live dermatologist, and they don't report the outcome of that. I did find one study, and they talked about the financial impact to children's hospitals of a telemedicine program, and reported that it was positive. And that wasn't just genetics. That was a telemedicine program where they offered their subspecialists to outlying hospitals to do consultations, and this reported that it increased the referrals to the hospital, and it increased the bottom line of the hospital. Not necessarily the subspecialist, but it increased the bottom line to the hospital. So whether you can use that as an argument for it to the hospitals if you're interested in doing it, don't know. So Like I said, I wanted to leave time for discussion and just, kind of see what people's thoughts are and see if we can conclude anything. The physician shortage, I think, in genetics is real, and it's not going to get better anytime soon. I didn't address genetic counselors, dietitians, all of the other people that help us keep the lights on, the doors open in genetics clinic, because I think, that's a much bigger, harder to tackle question. And I know we certainly have good nutrition support, but, they tend to be one or two in every center, and they're generally overloaded. It's like we talked about this morning with Ronnie. When a new PKU patient's born, they're on the phone all the time, every week. And that's just PKU. I mean, never mind all of the other things that are being picked up on newborn screening now. I mean, the people who are in place are generally working as hard as they can work. Telemedicine has the potential to help, but it's like I try to explain to my chairman who thinks telemedicine will solve everything. You still need somebody on the other end. You may have a geneticist who can tell somebody what to do, but there still has to be somebody to do what needs to be done on the other end. So how much are you really saving? And I think that's the problem I see with it is, it's so many barriers. I mean, even us who do this day in, day out, trying to get the right test to the lab, just trying to get the right test to the lab and get it back is not easy. So when you've got, if you're the talking head who's telling somebody, well, just order, that transfer and isoelectrophoresis, and we'd like it to go to yada-da-da-da and get a microarray, then they're going to find out that, oh yeah, Aetna's not paying for microarray. What do we do now? Well, I don't know. I guess you don't, I don't know what you do. Maybe you don't do it. Maybe we go back to just doing chromosomes and Fragile X on everybody. So that's a problem. And we have to use our village effectively. There are things that I do that other people could probably do just as effectively. Anything that doesn't involve actually examining the patient or treating the patient, giving the infusion, or the things that I could offload, probably. The counselors ideally wouldn't be spending their time trying to beg the insurance companies to let us do the tests that we know need to be done. So that's a problem. But how do we change things to get where we need to be? Education of other specialists and the integration of counselors into their specialties. Can we send a counselor to neurology clinic to make that to make it so that patients can get their workup started earlier, or maybe help the neurologist do some of the initial workup, or decide who really needs to see genetics and who doesn't. Those are all things that certainly I've thought about. And with that, I'm going to open it up for discussion, because I would love to hear other people's thoughts about what they think, what experience they've had, and ideas about where to go.
I wrote down a couple of things here. One, Hans and I talked about this, cost of medical school, and the salaries that clinical geneticists get are barriers, because if you've got $200,000 of debt when you come out of medical school, picking a lower paying, some might argue the lowest paying subspecialty you can may not be advantageous to your financial health and or your spousal relationship. The other one is, I think a lot of people don't want our patients. You're saying they don't want our patients because they're complicated and they take too much time. And when you're constantly being expected to turn them over, it's not a barbershop. It's patient care at its finest, I hope. And the third thing is, should we be lobbying for all pediatric residents to be required to do a genetics rotation, not just having that as an elective, but at least getting a chance to expose them that may lessen our workload down the road, because there's a 6 to 12 month waiting time to get to see a clinical geneticist at many places. Maybe that would help them get the ball rolling, or maybe we might find that person who's really interested in becoming a clinical geneticist.
Well, I agree with everything you said. I actually didn't address the whole salary issue, not because I don't think it's important, just because I didn't want to sound like a whiner, you know. Yeah, but it's real. You know, the salaries, if you look at that salary survey, they've come up. But if you look at it compared to, say, you know, a neonatologist or, you know, somebody else, it's not a neonatology salary by any stretch of the imagination. And the other thing is, I mean, there are good people who say, I'm willing to take a lower salary, but I think, you know, we kid ourselves if we don't talk about what happens when they do rotate. And I think they should have to rotate. I think it's just, I can't see why the AAP would not require genetics with all the advances in medicine and genomic medicine. I can't for the life of me see why they would not require that. But that said, I think when they rotate with us, they're not stupid, and they see how hard we work, and they see how we get treated by our institutions, by the medical center in general. We're not the guys up at the top with the good view, you know, most of the time. We're down in the basement, you know, with the equipment everybody tossed out. So, you know, I mean, we routinely send our secretary to scavenge for office supplies. So, you know, I mean, people see that. They're not stupid. And I think they look at it and go, you know, yeah, you really have to love it. And, and so I think that's a barrier, too.
Is this on? Yes. I did it my way. As a former residency director, you know, knowing the RRC and all that, I mean, the required specialties you get exposed to in training, it's self-serving because they're subspecialties of the American Board of Pediatrics. Yeah. So that's sort of where that goes, and you only have so much time for electives, so, you know, you can see how the marketing goes into that. But I agree, you know, genetics should be part of it. I was going to talk about telemedicine, since I've had the most experience with telemedicine and genetics since 1995 till February 14th of this year when I stopped practicing. You know, telemedicine, you're right. The biggest problem is not technology, it's how you organize the service. And you do have to put a lot of investment into training the people at distant sites so they can seamlessly conduct an encounter there. But if you do that investment, it can be very satisfying for the patients and for the referring physicians, as well as for the clinician who doesn't have to travel 4 hours for an outreach clinic. And so that's one thing that you know, I like to encourage people, you know, to think about how to use telemedicine better. And hopefully now, in my role with the NCC, and we have a telemedicine, you know, telegenetics is it technically, work group, that I can help provide some input and some expert advice to people regarding that. The future of telemedicine is mobile, you know, and one of the visions I have is that pediatricians or primary care doctors would have the opportunity to use a mobile device at what I call the point of concern in their office with the patient to consult a geneticist. Because right now, you know, they see a kid, they go like, maybe he should see genetics, but I got to send it to my referral person who does the paperwork to make the referral, and then it's 6 months before they get seen. And so the threshold of making the referral to the geneticist is so high that patients not getting services. And you probably could get a lot more referrals if we had point of concern access to expertise. that we'll talk about some more. But anyway, I think that we need to rethink our model of how we provide care as well. And the biggest obstacle to that is the fact that right now in our system, you have to create billable events. And we spend so much of our time with that administrative stuff. And that's just, you know, to get that minimum return we get anyway is just like really bad. So, you know, the big projects with the ACA that are going on in the regional groups and with the NCC are starting to address some of the implications of the ACA for specialists like us. And so there's some hope on the horizon. So I want to like be a little more optimistic here. You know, like those of us who are in the declining part of our careers, hopefully we can help, you know, bring about some change.
Yeah, that's good to hear. I mean, my question back is, you know, you generate these referrals, who's going to see them? Because, again, it speaks to changing the model because, like Curtis said, there's a 6 to 12 month waiting time to see a geneticist in
Right.
most places.
Right, but by the same token, if a pediatrician has a kid in his office or her office, and they got a mobile device to take a picture of a kid they're concerned about, put some clinical information, and they send it to you as a store and forward consult, you could look at it, you know, take 15 minutes, send a reply, you know. Of course, this is time you would be documenting the EHR at home after clinic, but,
Right.
you know, you could then give them advice about what to do and things of that sort, and perhaps make the visit more efficient when you actually see the patient.
Yeah.
That's the kind of thing I'm talking about. We
No,
need to start thinking about.
And I agree, and one of the, we were talking about it at lunch, one of the barriers to that is it's so doggone hard to order labs. I mean, I tell the pediatrician, order this chromosome microarray.
Yeah.
And even if they can find it on the Quest form,
Right.
you know, the insurance may not pay for it, they have to get a pre-authorization, yada, 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 and they just say, oh, the heck with this, just refer them.
Yeah, we always would fax a completed form to
Okay.
our telemedicine encounters. I'll yield the floor.
Let Hans finish it up here and we'll go to the next.
Thank you. I appreciate David's positive perspective, and he's done a lot to help us with telemedicine. We look forward to having more of that from you. In addition to having somebody on the other end of telemedicine running the session with the patient, the geneticist has to have time to do those sessions, and most of the geneticists I know don't have spaces in their calendar. And so something has to give up if you're going to have time to do additional clinics through telemedicine. Most of the people I know doing clinical work are completely covered up. Their clinics are not looking for patients. So new referrals would be great if we had new physicians, and I hope we will soon, because there are a lot of students here. And it really is the best field of medicine.
Don't want to be negative or discouraging. It's just, you know, this is our reality. And we have to really look at what we're doing. It is the best field. It is the most interesting field, or else I wouldn't have been in it for 25 years. But we've got some tough problems.
If she's so positive, I want to know why she kept showing me the northbound end of a southbound horse. We are covered up, Hans. We're more covered than that proverbial Speedo at the beach, so that's for sure. So our